Good morning, everybody, and thank you, Dr. A.M. sir, for giving this opportunity and the confidence that I could start dealing with these cataracts on my own. So I have no financial interest to disclose. So basically, I'll start with some theory, and if time permits, I will show two or three cases. So we know that cataracts occur both after full thickness and lamellar corneal grafts. Most of the patients which we see in follow-up in OPD develop some form of nuclear or cortical cataract within the first 5 years of doing the keratoplasty. And if the indication was a therapeutic keratoplasty accompanied by inflammation inside the eye, within first year you develop some form of cataract which may need surgery. So basically prolonged steroid use, intraoperative iris manipulation, age more than 50 years, female patients and patients with Fuchs dystrophy are at more risk of developing cataracts after keratoplasty. So we'll deal with these points one by one. One is the timing of the surgery, then optimizing the surface before the surgery, the role of biometry and topography or tomography, selection of IOL, anesthesia, the location of the incision, the construction of the wound, and the type of surgery to remove the cataract, the role of viscoelastics and irrigating solutions, the perioperative management. So when do we tackle this case? So basically the surgery decision varies from patient to patient and the surgeon's comfort. It's also the amount of visual deterioration and the quality of life the patient is undergoing. So if it's a sutured graft, we have to wait ideally till the wound is stable, that is a minimum of 6 months, and ideally till all the sutures are out, that itself can take about a year. But if there is a mature cataract or a lens-induced glaucoma or a gross subluxation or dislocation, we have to undergo do the surgery immediately, even if the sutures are in situ. And the ideal way to go about it is to call the patient just to see if the measurements are reliable and stable. You can call them at 2 sequential visits at a gap of around 3 to 6 weeks, see if the readings are the same, and then you can undertake the patient for surgery. So optimizing the ocular surface is important. We know that there is an increased incidence of dry eye and ocular surface disease after keratoplasty because of the disturbance in the corneal innervation. So you should have a high index of suspicion that the dry eye is already there and have a low threshold to treat it. So artificial tears are more than enough in most of the cases, but if it is more severe dry eye or MGD, then you can add additional treatments till the surface becomes stable. Also rule out NLDO and correct any lid abnormalities or malpositions before you perform the cataract surgery. This is the most tricky part of the equation. So generally if you are doing a cataract surgery, that it is assumed that the graft is clear in the center. So mostly the modern machines can give you a good idea of the keratometry and the IOL power. So as I had mentioned before, the surface should be stable, all sutures are out. If you have access to the optical biometer, it's the best. But if not, you can also try getting readings via the manual keratometry method and A-scan if the cornea is a bit hazy. You can also refer the patient to a colleague who has access to these machines and then take a combined decision that which power should be implanted. Tomography helps in the irregular corneas. Mostly these grafts, the sutured grafts, are quite irregular and also helps to reconfirm the IOL power and use the newer IOL formulas. Which IOL should be selected is basically the entire graft is a system of compromised optics. It is not on the normal eye or normal cornea. A standard monofocal IOL is the best. If the astigmatism is significant enough, which is generally the case, you can go for a toric IOL. And if the cylinder is very high beyond the range of commercially available toric IOLs, you can order a customized toric IOL from some of the companies. Best to avoid any modern IOLs like the EDOF or the multifocal IOLs. Anesthesia, topical anesthesia like a routine phaco is the standard of care. However, in certain cases like the patient is uncooperative or you are planning a SICS or a ECC, you can choose a peribulbar anesthesia or a subtenons. Pediatric cases, obviously there is general anesthesia. Avoid massaging the eyeball and giving a pinky after giving the block. And you can use intravenous mannitol to reduce the pressure before the surgery. The incision should be generally clear corneal, but keep it away from the graftose junction to avoid a Descemet's detachment there. The compromise is do a shorter uniplanar incision and then suture it at the end. If there is a limbus to limbus large therapeutic graft, there is no space to put the incision, you can go limbal or even more posterior, make a scleral tunnel and do the phaco. Now, whether you do a phaco or a ECC or a SSS depends on the case, the density of the cataract and the surgeon's skill. Any of them is preferable, there is nothing good or bad as long as the surgery is safe. And these wounds are prone to leakage because of the abnormal corneal contour. Just have a lower threshold to suture the wounds. I personally suture all the wounds after doing a cataract in such cases. We should use a soft shell technique and use of dispersive viscoelastic like to cover the endothelium. As an institutional practice, we use balanced salt solution in all the cataract cases. And if the endothelial counts are poor, that is generally the case after post-therapeutic cases, we can use BSS plus. It has shown to protect the endothelium much better than the other irrigating solution. Keep on replenishing the dispersive viscoelastic and the acid. Don't be shy. You can use an entire syringe if you want to, and lower the flow rates. Do a slow phaco when tackling such cases. And since we are manipulating the anterior chamber and inciting inflammation in a quiet eye, there is a high chance that the graft can reject. So from the baseline, just step up the topical steroids at least 7 to 14 days before the surgery. And only when you are sure in the post-operative period that the eye has become white, there is no inflammation, start slowly tapering the steroids and bring them back to the original level. And if you know that the surgery was done, the graft was done in a patient who had herpetic keratitis, start the oral antivirals 7 days before surgery. And in such cases, do not disturb the graft epithelium because it's very notorious, it doesn't heal because the cornea is neurotrophic. And the most important part is counseling. It's a high risk, high stakes surgery. You need to give more attention and more chair time in the OPD compared to your normal cataract cases. There is a high chance of graft failure because the endothelial counts are poor, so regraft probability is always there. You need to explain it verbally to the patient and the attender, and also mention it in your prescription that a regraft may be needed. Please set realistic expectations, under promise and over deliver. And if there is always a chance of a refractive surprise, the patient may need one more surgery to address the residual error. So counsel for that also. Do I have time? So we'll go to the first case. So this was a therapeutic keratoplasty, 7.5, 8 millimeters, which was done in 2022. I had removed almost all the sutures by around 9 or 10 months. So this was the pre-op photograph. You can see the graft is quite clear. It's a smaller graft. You have enough space to put a clear corneal incision. The endothelial count as expected is quite less, but the pachy is fine. So we expect that we won't have much edema in the post-operative period. The biometry is tricky. So in the left eye, the optical biometer is giving us a cylinder of almost 11 diopters. The right eye, the axial lens are quite okay. So we counseled the patient for a cataract surgery and also a toric IOL. So this is the surgery. Please forgive the video is slightly out of focus. So on the right, you can see this is how it actually started. The patient presented with a non-healing full thickness corneal ulcer for which the graft was actually performed. So the axis marking has been done. You can see there is some focal area of synechiae in I am sitting temporally. So you are making the incision away from the graft-host junction. So this is sort of a compromise. It is a shorter tunnel. It is uniplanar, and obviously you are going to suture it in the end. Very gentle hydrodissection, and basically the surgery has to be done quite slowly compared to the normal speed at which you may operate for your other cases. Each step has to be slow and deliberate. I generally don't perform a direct chop in these cases. I do a stop and chop. So now the nucleus management has been done. The irrigation and aspiration has been done. I am just injecting the IOL. So this patient has started out with a cylinder of around 11 diopters. So we are trying to put the maximum available, commercially available toric. It's not a customized IOL, it's just a normal toric. You just align it, remove the viscoelastic above and below the IOL. So this was the outcome at around 2 months after the surgery. The photo is 2 months post-op. The patient has achieved a vision of 612 for distance with a residual cylinder of 4 diopters and a spear of 2, so that is a surprise.
Thank you, Aditya.
Yeah.